Hello, my name is Stuart Goldstein and I'm a pediatric nephrologist at Cincinnati Children's Hospital Medical Center in Cincinnati, Ohio, United States. I'd like to thank the organizers from Clínica Alemana, as well as my good friend Felipe Carvanero for inviting me to give this presentation on our NINJA program. NINJA stands for Nephrotoxic Injury Negated by Just-in-Time Action. The high-level rationale for NINJA came about over a decade and a half ago. What we realized was that nephrotoxic injury is one of the most common causes of acute kidney injury in non-critically ill hospitalized children. We also saw that a portion of nephrotoxic medication-associated AKI goes unnoticed due to the lack of systematic kidney function surveillance in exposed children. There are multiple studies that show serum creatinine measured at least every 4 days occurred only 50% of the time in children receiving multiple nephrotoxic medications. And we thought that nephrotoxic AKI could be a potentially modifiable adverse safety event if at-risk patients could be identified, if that would lead then to systematic serum creatinine monitoring reliably in at-risk patients. And we thought that AKI could possibly be avoided or mitigated by reducing unnecessary exposure. Our NINJA vision statement has been and will always be children should only get the nephrotoxic medications they need for the duration they need them. And what's important to realize there is that we understand children who are being cared for in tertiary and quaternary hospitals need nephrotoxic medications because these medications treat underlying malignancy, heart failure, infection, etc. And so it's not that children shouldn't get nephrotoxic medications if these are the medications that are important to improve their outcomes, but they should only get the ones they need for the length that they need them. And by being very, very precise and observant, we hope through the NINJA program that we could decrease nephrotoxic medication-associated AKI and its sequelae. Back in when I was at Texas Children's Hospital in Houston with Michael Zappatelli, we started to look at aminoglycoside-associated nephrotoxicity. We looked at kids who received an IV aminoglycoside for 5 days or longer. We excluded patients with primary kidney diagnoses, and we followed children for a year. There were 557 unique children in this study. 95% of them were older than 3 months of age, and depending on the AKI definition used at the time, whether it was the P-rifle criteria or the akin criteria, acute kidney injury occurred in 1 in 5 to 1 in 3 of these children. And serum creatinine was measured at least every 4 days, only 50% of the time. So it's certainly possible that the AKI rates were higher. But let that sink in for a minute. 1 in 5 to 1 in 3 kids exposed to a very common antibiotic develop acute kidney injury. And I don't think we often talk to families about these risks ahead of time. Brady Moffitt, who at that time was also at Texas Children's Hospital and a pharmacist, looked at acute kidney injury and increasing nephrotoxic exposure in non-critically ill children. So we looked at 350 non-critically ill children who had acute kidney injury by the P-rifle criteria, and we matched them by age, gender, and primary hospital service to children without acute kidney injury. We looked at 38 potential nephrotoxic medications, and we compared the nephrotoxic medication exposure rate between children who had acute kidney injury versus those who didn't. What we found, these are non-critically ill children, and so this may be surprising to you, it was to us, that 86% of children in a hospital like this were exposed to at least one nephrotoxic medication. 9 out of 10. To me, this is the most common exposure that a patient has in a hospital next to the need for hand washing. Patients with acute kidney injury had a 70% increased risk for exposure to a nephrotoxic medication, and the positive predictive value for acute kidney injury doubles for children who were exposed to 3 or more nephrotoxic medications on the same day. So, nephrotoxic medication-associated AKI is one of the most common causes of AKI in hospitalized children. In early studies, it accounted for anywhere between 16 to 20% of all AKI. Recent studies have demonstrated, which I've shown you, that nephrotoxic AKI occurs at a higher than previously recognized rate. And a portion of it likely goes unnoticed due to the lack of kidney function surveillance in susceptible exposed children. So our hypothesis was that more reliable surveillance of nephrotoxic medication exposure and injury would demonstrate that the rates are high and that an epidemic exists in hospitals like ours. The objectives of NINJA were to develop an electronic health record-based AKI screening intervention to assess for changes in AKI prevalence or duration, what we call intensity, and to reliably quantify the rate of high nephrotoxic medication exposure and associated AKI in the non-critically ill pediatric population. We did not initially start with the ICUs because we know that creatinine is assessed more frequently and more reliably in the ICUs, and we felt that many of the nephrotoxic medications that are received in the ICU are non-negotiable, and so we did not want to start there. The methods: we found nephrotoxic medication exposed patients prospectively. We instituted a reliable monitoring of serum creatinine for evidence of injury. We measured the exposure and injury rates and the changes over time. And we used electronic triggers within the EHR and automated reports to make the process more efficient and complete. The criteria that we initially started with and now 12 years into the NINJA project are exactly the same. Are kids who are receiving 3 or more nephrotoxic medications on the same day based on Brady-Moffitt's data, or an IV aminoglycoside for 3 or more days, and a number of years into the project, an exposure to IV vancomycin for 3 or more days counted as an exposure. Here was our initial list from the first work that was done at Cincinnati Children's Hospital, and we basically looked at the Lexicomp compendium to identify medications that had a greater than 5% rate of acute kidney injury. Initially, we started with the P-rifle definition for AKI, and then over time, as the KDIGO criteria came out in 2012 and were validated in a number of pediatric studies, we transitioned over to KDIGO. We developed 4 novel outcome measures, and I'm going to go through these in detail because it's important to understand what these metrics are actually measuring. We looked at the high nephrotoxic medication exposure prevalence rate per 1,000 non-ICU patient days. Every week, we would total up the number of patients who were exposed to nephrotoxic medications in one of those 2 ways, 3 or more on the same day or an IV aminoglycoside for 3 days. And then we would divide that number of patients by the number of hospital days in the non-ICU units. So this measure generates a normalized rate of exposure cases per week. We then looked at the AKI prevalence rate also per 1,000 patient days. So of those patients who were exposed, we looked to see how many developed AKI during their exposure time. Now, the patients could be exposed for more than 1 week, and if they developed AKI, say, in the 2nd week of exposure, we still put the AKI episode in the first week of exposure in order to maintain some consistency in reporting. So this measure generates a normalized rate of AKI per study week. Then we looked at the rate of patients with AKI who were exposed. So this is just a percentage of exposed patients who develop acute kidney injury. And then the AKI intensity rate is the number of AKI days that a patient had, so the number of days they had acute kidney injury per 100 nephrotoxic medication exposure days. And what we felt would happen is if you had more reliable monitoring of creatinine, so daily instead of every 4 days, you would detect acute kidney injury earlier and then hopefully decrease the exposure to nephrotoxic medications if possible, and therefore decrease the days in AKI. We thought this was the metric that we had the best chance of demonstrating an improvement. The process, and this is still the process today, pharmacists initially created but now receive daily reports generated from our electronic health record. They verify and validate that the patients who were exposed actually were exposed to 3 or more medication nephrotoxins or an IV aminoglycoside. Then they provide serum creatinine suggestions to the rounding team if necessary. And the recommendation was for daily creatinine screening when patients were exposed. Then we had a data analyst who compiled the registry from the pharmacist reports. We generated the metrics and run charts, and we shared with our AKI team, with hospital leadership, and other stakeholders. And I cannot overemphasize the importance of this because we need to show people that actually AKI rates are high, and they may be high in higher than anticipated or realized by certain services within the hospital. So our algorithm is as follows. Patient meets high nephrotoxic medication exposure, and then a daily creatinine is recommended. Here's the exposure surveillance loop. As long as the patient is exposed, then a daily creatinine is recommended and ordered. And for the 5 days after exposure ends, just to make sure that we don't miss any acute kidney injury after the exposure to nephrotoxic medications ends. And what we found was that 14% of all nephrotoxic associated AKI in NINJA occurred in the 2 days after discontinuing the medications and the patient was no longer exposed. So we have now truncated that to only following patients with serum creatinines for 2 days after exposure ends. The injury surveillance loop, as long as patients, if they do develop acute kidney injury, have acute kidney injury, then we monitor their serum creatinine until they return to baseline, and then for another 2 days after returning to baseline to ensure that the AKI episode has actually been resolved. And then we end surveillance at 30 days if a patient has had AKI for 30 days and has not recovered. So what are our results? Well, the first experience from NINJA was published in 2013 in Pediatrics, and this was the first year after NINJA implementation at Cincinnati Children's Hospital. We had around 32,000 admissions. We excluded 4,500 for ICU admissions, and then we had a number of patients who had repeat admissions, and ultimately we had 726 unique patients who were exposed, and there were 945 exposure events, so a number of repeated exposures. This accounted for 2 to 3% of our non-ICU census on any given day, or around 20 to 25 patients per day. Now, these are not new patients. Many patients, as you would imagine, are exposed for prolonged periods of time. So this was not a huge burden once we identified the patients. The burden really is in developing the systems to identify the patients. We had 99% compliance with daily serum creatinine monitoring in all of the exposed patients. And the most often, or the most common reasons for not getting a daily creatinine is if it were a patient was a small baby, an infant, and they asked if we could go to every other day, or if a patient, say, for instance, has a heart transplant and is on 3 nephrotoxic medications to prevent rejection or infection chronically. This is not really a new exposure. And the team would ask if we could go to every other day or 3 or twice weekly. And we always said yes. We never mandated that folks followed NINJA, but you can see our compliance rate was very high. So this is the first run chart over the first year, and this is the high nephrotoxic medication exposure rate. And what you can see is once we initiated electronic health triggers, we detected a lot more exposure, about 30% more exposure than the pharmacists themselves. And that's not a knock on the pharmacists, but in this kind of work in a busy hospital, automation is always going to do a better job in detecting patients. So what does this exposure rate mean? Again, it means that every week there are about 11 exposures per 1,000 patient days in the outside of the ICU. The AKI rate went between 2 to 4.3 AKI episodes per 1,000 patient days. And that's kind of a difficult metric to interpret. But if we put it in the context of other health-acquired conditions, our initial AKI prevalence rates were 10-fold higher than catheter-associated UTI rates and 3-fold higher than central line associated bloodstream infection rates at Cincinnati Children's. And obviously, those are very, very important healthcare conditions and acquired healthcare conditions. What this tells you is that actually an epidemic may exist with respect to nephrotoxic injury. In the first year, we demonstrated a 42% reduction in the intensity rate. So the number of days a patient had AKI per 100 exposure days went down by 42%. This is the metric we thought we would improve Then, over a period of time, we looked to see if we would have other improvements and reductions in the NINJA program. So this is still single center at Cincinnati Children's, but a 3.5-year experience. And what you can see over these 3.5 years is that we had a 38% reduction in the exposure rate in non-critically ill children. We never told any service that they could not use specific nephrotoxins or combinations of nephrotoxic medications, but we fed the data back to them. And then certain service lines like the pulmonologist taking care of patients with cystic fibrosis, or the transplant physicians taking care of patients with liver and small bowel transplant, started to standardize their nephrotoxic medication exposures and the time and duration that patients were exposed. So by standardization, without any data to suggest or demonstrate that one method is better than the other, we were able to demonstrate really a passive reduction in exposures. And over that time, we observed a 62% reduction in the nephrotoxic medication-associated AKI rate per 1,000 patient days. We also observed a 33% reduction in the nephrotoxic medication-associated AKI rate per exposure, going from about 1 in 4 episodes to 1 in 6 exposure episodes leading to AKI. And this rate has stayed persistent and even slightly better over the ensuing years up until the last week at Cincinnati Children's. What we did in this study is we tried to make an assessment of how many exposures we avoided and how many AKI events we have avoided potentially. So we assumed, if we assumed that NINJA had never been instituted at Cincinnati Children's, and we assumed that we would have had the same exposure rates and the same AKI rates, and then compared to what we actually observe, we estimate that we avoided over 600 exposures in 3.5 years and nearly 400 AKI events in those 3.5 years. So it's great that NINJA worked really well in Cincinnati and that the nephrons of children in Cincinnati were being protected, but it's really not all that helpful if we can't disseminate projects like this to other centers. And so we received a grant from the Casey Lee Ball Foundation and AHRQ from the United States government to disseminate NINJA at 9 children's hospitals. We wanted to measure the impact of NINJA on AKI in these hospitals, just like we saw in Cincinnati. And the novel part of this is that we also wanted to assess for an association between contextual measures, including participation in our collaborative, the resources of the collaborative, pharmacy involvement, etc., by individual hospitals across the network. We wanted to take these learnings from this 9-center incubator so that we could spread NINJA even further and wider more efficiently based on what we would learn here. What did we find? Well, very similar reduction in the AKI rate per exposure from about 1 in 5 to, again, 15 per 1,000 patient non-critically ill ICU days, so 1 in 6, exactly what we saw in Cincinnati. And the Cincinnati Children's was not part of this 9-center collaborative. We estimate here over 2 years, we avoided 242 AKI episodes in the NINJA collaborative. We also demonstrated a 23% reduction in AKI rates per 1,000 patient days. When we looked back at the service lines that were associated with exposure and with AKI, it is no surprise that bone marrow transplant patients and that service represented or comprised a very high percentage of exposure and acute kidney injury, and so did oncology. And we never would have thought that we could decrease AKI rates in these very at-risk patient populations. But Stephanie Benoit, who is a pediatric nephrology colleague of mine at Cincinnati Children's, and Dr. Davies and her stem cell transplant group at Cincinnati Children's decided to take on an interventional study to see if we could reduce AKI rates using the NINJA backbone as the foundation. So the old protocol was in place since NINJA started from 2011 to 2016, and we started getting some baseline data for patients who had stem cell transplant and had fever and neutropenia. And in 2016, we changed how patients were treated. Prior to 2016, patients, if they were neutropenic and had fever, were started on piperacillo, tazobactam, and then the duration of the therapy was at physician discretion. And they all received vancomycin for a duration of physician discretion. Starting in 2016, Pip-Tazo was changed to cefepime, and if the cultures were negative, then antibiotics were stopped. And the same thing was true for vancomycin. The duration was dictated by culture results. What you can see in panel A here is that there was a very high fidelity to changeover. So the graph in A shows the dramatic reduction in pip/tazo exposure, and concomitantly or simultaneously the increase in cefepime exposure for children who had a bone marrow stem cell transplant and fever and neutropenia. And you can see the days of vancomycin also decreased in this population. You can see overall the days of nephrotoxic medication exposure decreased in panel A, and who would have thought, but we had a 70% reduction in the days of nephrotoxic medication-associated AKI in this population. If we look at the pip/tazo era to the cefepime era, we can see the intensity goes down, the days of each stage goes down as well. Fewer stage 1 days, fewer stage 2 days, and fewer stage 3 days. For our patients who have either leukemias, lymphomas, or solid tumors, we did a similar sort of interventional study with Jennifer Young, who is the pharmacist for that group, and a number of the oncologists at Cincinnati Children's. And there were a number of additional changes that we made. In addition to pip/tazo, any patient who was undergoing a contrast procedure underwent the contrast nephropathy reduction protocol with alkalinization of the urine and hyperhydration as part of this work. We looked at a number of different root causes and key drivers and made all of these changes at the same time as well, just like we did in the bone marrow transplant group. And you can see again here, after institution of each of the different methods, vancomycin stewardship, nephrotoxic medication stewardship, contrast, associated AKI prevention, again, we saw a decrease in the AKI rate in this very vulnerable population. Now, David Ashkenazi and his group at the University of Alabama at Birmingham and Children's of Alabama undertook Baby Ninja, where they put in a practice for nephrotoxic medication identification, exposure, and reduction for AKI in their NICU. And what you can see here is that the green line shows you a very low rate of serum creatinine surveillance, and in the green, yellow and the green shaded areas, an increase in the rate of serum creatinine surveillance. And you can see in the blue a decrease in the exposure rates, and in the red, a decrease in the AKI rates. So we often think if we're going to detect more AKI, if we're going to get serum creatinines more frequently and more reliably, we'll see higher rates of AKI. And in fact, it's really showing showing people AKI rates with adequate surveillance that we end up decreasing AKI. So I have to thank the folks at the Center for Acute Care Nephrology who do all of the work behind the scenes. So I get to give talks like this, and I hope I get to come to Chile in the future. Have to acknowledge Devesh Dahali, who is the really ninja partner in crime. He really did a lot of the work to energize the Ninja Collaborative through novel methods of quality improvement and quality assurance. Here are the Ninja Collaborative Group, the 9 hospitals, and their representatives for a learning session in Cincinnati. I have to thank the research support for all of our endeavors, including Ninja at Cincinnati Children's. And I thank you for your attention, and I look forward to taking any questions in the question and answer period. Thank you. Thank you.